communities have had a nurse come out already to support with some of their pre-clinic planning. So some of this stuff's already been discussed at length, but I'm going to review the roles with everyone on the line, and we can follow up with just it's a very brief description of each role if you'd like to have that in writing, but the community health leads have been provided with this in writing as well. So the purpose of just everyone understanding their roles and how they may fit into a scenario of anaphylaxis is just so that we're all very prepared. In the event that something transpires at one of the community clinics, we want to ensure that everyone is able to respond and we aren't panicking, recognizing that everyone's going to play a very critical and super valuable role to the smooth running of the clinics, and so appreciate all the great support that we're getting from community to help with this. You know your community the best, and that's why they're going to be seeing you first. So the first role is, we've named it the greeter. So this would be somebody that's outside. Most likely you might have more than one person acting as a greeter, somebody that your community is familiar with. And they're just going to have up to community if they want them to have the list of client names for appointment, but just confirm that the client has an appointment and directing them what to do if they don't. So this is going to be dependent on community, and if we have a full booked day, if we're going to hold a couple of clients to wait on the sidelines, if there is an opportunity where somebody didn't show up, that would be the direction that they would be given. So somebody that's just going to, warmly welcome them, confirm they have an appointment. And then the next person is going to be a screener. So this person's going to review the COVID screening questions with the clients before entering the building. So the reason why we're going to do this is two reasons. One, we don't want to have anyone that's unwell attending any of these clinics. And two, there is... with the vaccine, we don't want to have anyone with symptoms because we want to know if those symptoms are something that need to be tested. We would be encouraging anyone to get tested if they meet the criteria, and then knowing if a symptom was from the vaccine that they received or something that was already going on with them prior. And then we're going to have that person also ensuring that folks use hand sanitizer and that they're wearing a mask. We do want to encourage community members to arrive with a mask. It's pretty common, now that we need to have one. So if they arrive without one, then there will be masks to provide. The next role would be reception and check-in. So this is most likely going to be the FNHA support staff that come. If there was somebody from community that was really wanting to be a part of registration, it would be something that we have to plan for in advance and get registered for the e-form. It's very simple, and then you just put a very simple app on your phone, but it does take a little bit of time to get through the process just to get your identity confirmed and things like that. It's a government app. And the e-form, many of you may have seen emails about it. It's already been taken care of for everyone that's supporting from FNHA. Like I said, if there's anyone from community that wants to participate in registration, we'd have to get them registered for the e-form. And this person would be checking them in, and they will be, if they brought their PHN number, which is what we're really hopeful for most of our client participants, their information is pulled up very easily with their PHN on the e-form. And if they don't have their PHN, then it all gets entered manually. So the PHN makes things faster and more efficient. And if clients don't have the card, or if they don't have a card period, they could bring in a prescription bottle or something like that that would have that on there, or they could contact their family doctor perhaps, or their pharmacist. Somebody should have that number for that client. So that
I'll just jump in real quick, Laura. A prescription bottle won't have their care card number on it. Only a prescription receipt would have a care card number on it.
Thanks, Carmen. We were told pill bottle.
No, so they have an RX number, but not a PHN on them. Okay, so the PHN is only on the receipt.
The paper little leaflet that goes with it?
Yeah, the little piece that comes with it.
Thanks for jumping in.
Yeah, no, I was like, that's really important.
Oh,
and I mean, a bottle would give them we could call the pharmacy then and find out, but it's easier to have the receipt.
Yeah, we're trying to make it as easy as possible. So thanks for that, Carmen. So
yeah,
you know, your prescriptions and you get the few papers on the side, that'll have the PHN, but not the actual bottle. Awesome. Okay. All right. Great. So the other little tasks for that reception and registration area is going to be providing the post-vaccination handouts and directs them to the appropriate immunization station. So the clinics are being set up and then they're going to be lettered or numbered. So then it's going to be like, you know, A, B, C, D, 1, 2, 3, 4, and then clients will just get directed where they go to. Once they reach the immunizing station, the immunizer will review the vaccine checklist and go over the components to obtain informed consent. They'll then provide the vaccine, complete the e-form at the station, and then direct the clients to the waiting area. We do have to keep folks distant during their 15 minutes of waiting. And then this is where the last role comes in, or one of the last roles, post-vaccine monitor. So this person watches waiting clients for concerns, notifies the nurse if there are concerns, disinfects the seats between the clients, and ensures clients are maintaining the COVID safety protocols. So that includes the space, keeping their mask on, etc. And then monitors time if requested, just because there's that 15 minutes that needs to be stayed for. And this post-vaccine monitor is not taking these clients away from where the nurse or the immunizer people are. They're still going to be in eye shot of the immunizers, but just to have extra eyes on folks and to alert the immunizer if anything is going on. The only role that I didn't notify community of, because this will be held by mostly FNHA staff, is a lead. So the lead person is going to have just a few tasks. If there's any needs for the clinic that are discovered, they're going to reach out and then we'll arrange for those necessary supplies or whatnot to be brought to the clinic. And then there is a requirement at the end of the day for some very important reporting. So to get all the information from each clinic to be reported by the end of the day, the reporting will be done by myself for the Lillooet area clinics. And then the lead person will just hand over the information. And it's very simple about, you know, vials open and doses provided. And we are, you know, striving to have a zero waste policy throughout all of the clinics across the province. It's a zero waste policy. So as we wind down closer to the end of the day, we have to be very cognizant that we are finishing in groups of 10 so that we have used every dose of the last open vial. So I mentioned when planning the clinics is to try to have a list of people that will be at the clinic and not necessarily give them a clinic time, but to have a list of people to draw on when we're needing to either fill gaps because maybe a group of people didn't show up, or at the end of the day, there's a few doses that need to be used up. That will likely be when the support groups, so coming in like our staff, that's the plan to immunize at the end of the day. If there were any tribal police or others in community supporting clinic on that day, that would be a good opportunity to pull those people in for a vaccine if they were interested. And that's just sort of like the end of the day responsibilities. And that will be under that lead role, just to make sure all those pieces at the end of the day, when we're all getting tired, get completed and the information gets to where it needs to. Does anybody have any questions?
I don't think there's anything in the chat as well. I'm just gonna look.
Hi, Laura. Josephine here. I have one question on behalf of Ridge River. My question to you is, I was just informed that we're not having our COVID clinic on the 15th. The vaccine's not available. Do you know when there's a set date for the vaccine to be able to be received?
So we don't have a tracking number on the vaccine, but we have still been provided the date of January the 14th, which is Thursday. So we are working on a updated schedule to start clinics on the 15th. So clinic dates will be changed, unfortunately, due to the delay of the vaccine arrival. And then we have to also consider still with how the first schedule was made, was that the communities that we reach out to first, it's based off of remoteness as well as current outbreaks. So we have to adjust our new schedule with those same ideals in place. I'm hopeful that we will get a confirmation that the vaccine is, you know, for sure 100% going to be here for the 14th, but I haven't received that yet today. And I'm still, you know, just same information that everyone else has is what I have.
Thank you.
Just the one question or comment from Christina. She said she heard that people can get their call their band office for the PHN. I don't know if that's actually accurate. Most band offices may not have that. Any comment from anybody in the band office? Do you have clients' PHN numbers?
Faye here. I do have some here in our band office, but not everybody's. So it's from previous clinics and whatnot. I will have and hold on to previous numbers.
Thank you, Faye. Nicole? No. Anybody else have any comments? Okay, well, I think if there's nothing else, Laura, maybe we'll pass it over to Natasha to start the presentation.
Sure, I'm gonna head out. I'm working on that schedule that I was talking about with Josie there. So I'm gonna step off and hand it over to Natasha and Carol, and I know they'll do a great job. So thanks for putting together the presentation for everyone. I think it's such an important piece for everyone to be prepared, and I know a lot of time went into it in a very short time to turn it around and provide it. So thank you very much. And if anybody had any questions for myself after I'm gone, you can either leave them with Carol and she can send them over all to me together, or just email me.
Thank you, Laura.
Thanks, Laura.
Bye.
Awesome. Thank you so much, Laura, for that. So I'm just going to introduce myself. I think I know pretty much. There's a couple of names here I don't really recognize, but my name is Natasha Hattindy. I'm a community health practice consultant with the Interior Regional team, but I have been a community health nurse in the Lillooet area for 6 years. So that's how I know pretty much everybody here on the call. I'm originally from Newfoundland. My dad is Mi'kmaq. My mom is a settler, and I live and reside and play on this beautiful Northern St'át'imc territory. So thank you guys for having me here today. So today I'm going to be sharing a slideshow with you guys. I'll get Carol to introduce herself. Sorry, I don't know if everybody knows Carol.
I think I know most people. But yeah, my name is Carol Michelle. I'm a community health practice consultant with the Interior Regional team. This is my home, born and raised here, lived here most of my life, worked as a community health nurse for like 19 years, not necessarily all here, but around here. So I'm really happy that you're all here today. Thank you.
Awesome. So today we're going to be talking about Afi and anaphylaxis. So Afi stands for adverse events following immunizations, and then anaphylaxis is the severe reaction that can happen. The presentation is definitely very like nursing focused, but I'm going to try to not use like jargon and words so everybody can understand, because it's really great. I'm so happy that the support people are here and the community health workers, because you guys are going to be involved in this, and you have been involved with these sort of events in the past. So if, for those of you that are familiar with the immunization routine that we go through, we have some binders at the bccdc.ca website, and there are a series of binders that kind of guide us on how to deliver immunizations and stuff like that. So part 3 and part 5 at the website goes through the management of anaphylaxis and the AEFI stuff that we're going to be discussing today, if you wanted to look it up, and it goes into all the details, and we'll bring up this stuff as well. So the first thing we're going to discuss is the AEFI. So what is an AEFI? So an AEFI is an adverse event following an immunization. So it's any untoward medical occurrence that follows immunization and does not necessarily have a causal relationship with the vaccine or the immunization process. Temporal association alone, onset of an event following the vaccine, is not proof of causation. So basically, an adverse event following an immunization is any sort of medical issue that arises after an immunization. And the time period we're going to look into has to do with, it'll vary depending on what the situation is. But just because there's an event, an adverse event, or something that happens after an immunization, it doesn't necessarily mean that it was because of the immunization. But what the AEFI does, it's going to alert us to kind of have a further investigation of that event. So this word temporal criteria, so this is just referring to the amount of time that has happened between the administration of the vaccine and then the event. So this is going to be a big part in deciding whether you're going to report this. And you can find the details of the guidelines in part 6 of the manual. So I'm just going to open that up here because I just want to show you guys. It's a PDF. You download it from the BC CDC website. So it looks like this when you get it opened up, and you're going to scroll down to, it goes into all the details of what an adverse event is. But this is the part that gives the summary of the reporting criteria. So the temporal criteria is right here. So for certain things, it might be 0 to 7 days. It might be 48 hours. There's a couple here where it's months, 3 months or something like that. And then also you have to look at the additional reporting criteria would be found here. And most of them, it has to be physician diagnosed. It can't be just diagnosed by the client. So this is where you'd go to figure that out. All right, so important to remember that adverse events are generally mild, and severe adverse events resulting in permanent damage are extremely rare, and benefits of immunizations far outweigh the risk. And this also applies to our COVID-19 vaccine. As we know, in Canada, there's very rigorous processes in place before this vaccine was approved, and the benefits do outweigh the risk in the case of this one as well. So there are 4 major steps that's involved within AEFI reporting, and this is kind of everything you need to know on the one slide. So the first part is probably the most important part, because if you don't do this part, then the client's not going to really know. So this happens when the client comes in and you're giving them getting the consent from them. So explaining the vaccine, why they have to get the vaccine. You're going to also want to advise them in that session that of what the regular reactions of the vaccine are, and to report back to you or to their family doctor if they have an adverse event after their vaccine. So any sort of medical issue that comes up after a vaccine, they should be reporting back to you. And this is very important because sometimes clients go in to see their doctor, it might be a week after, and they completely forgot they got the vaccine. So important to remind them of this. The second part of this is to report to the public health unit. So any reportable event goes to them, and you're going to fill out your AEFI case report form, which we're going to have a look at here in a little bit. The third part of this is following up with your patient. So if a client has had a medical issue after a vaccine, we want to make sure we follow up with them, follow up with their doctor or any specialists that might be involved to see if they can get the second dose of this vaccine. And then the fourth part of this AEFI process is contacting the local public health unit. So that's just having good communication with them and reporting any questions that you have about the AEFI reporting. So sometimes this question comes up to report or not to report. So events that should not be reported are local injection site reactions and non-specific systemic reactions. So for example, headache, myalgia, unless they're more frequent and severe. And then events that obviously have other causes, for example, comorbid conditions. We do know that in clinical trial findings, they will be posted on the Moderna website, and you can kind of go and have a look to see what the rates of the different reactions are on there if you're interested in looking into that. But with the COVID vaccine, what they have seen and what we are seeing is pain, swelling, redness. So those local reactions that we see with most vaccines. And then the systemic ones that we're seeing with the COVID-19 vaccine are fatigue, headache, myalgia, chills, arthralgia, fever, nausea, vomiting. So these kind of symptoms would not qualify for a AEFI report. So they would not be reportable. The only way they would be reportable is if they were severe or if they were related to other symptoms or conditions that the client might have. So again, looking at that section 6 in the AEFI reporting guidelines will be a good place to go to see if the thing the person's reporting qualifies for an AEFI report. All right. So events that must be reported. So these are your serious life-threatening events that result in death, anything that requires hospitalization, anything that causes disability or are associated with congenital malformations. So this would be if we were giving to a pregnant person that was cleared and there was some issue after that, that would need to be looked into. Any events requiring medical attention, unusual and unexpected events, they all need to be reported. So also events that happen in clusters. So for example, something happened in a certain area that might be related to a certain shipment of vaccine or something, those also need to be reported just to kind of follow it. And just, I know this sounds like so crazy, but we haven't seen any serious events in the clinical trials of the Moderna vaccine, and some of the things that you've seen on the news and stuff, it's not yet connected to the vaccine. We're not sure if it's causal or not. So as of right now, there hasn't been any serious events related to the vaccine. If you have, we forgot to mention, if you guys have questions along the way, you can type them in the text box, and Carol is sitting by there and she can answer them, or she can interrupt me if it's something that's related to what I'm saying. All right. So very important to remember when you guys are filling out the form that the medical health officer that you're sending the report to has never met the patient. So you want to be specific as possible when you're reporting and include as many details so that the medical health officer can make the best decision. And then also for the COVID vaccine, you're going to want to include like a date range of when the next vaccine is going to be given. We don't have dates for the second doses yet nailed down, but just to have that in there. Anything that you can possibly think of to put in there that's related to the client, just put it in there and they can sieve through it. So this is the form that is going to be filled out for an adverse event following immunization. So I just want to show you guys where you can find that. So if you go to the bccdc.ca website under health professionals, and then you're going to go down, scroll down to professional resources, and there's a link called surveillance forms. There's a really nice handy thing here, and I would suggest to have this. I have it pinned to my Firefox browser. I would suggest to have this one pinned. And then under this adverse event following immunization is everything you need to know related to adverse events and anaphylaxis. So right here, you got your AEFI case reporting form. This here will help you locate of where you're going to be sending your AEFI report. This is the full document of Part 5 of the adverse event following immunization. There's also a really great user guide that you can pull up, and it goes through in detail each little box of what they're looking for in those boxes. And then in addition to that, there's also the anaphylaxis worksheet and the guidelines for management of anaphylaxis in non-hospital settings is under here that we'll be getting into. So I'm just gonna pull up the AEFI. Oh, sorry. That one is, all right, there it is. So it comes up as a Word document, and you can just kind of go in and fill in the various boxes and use the user guide. So several pages, you want to fill it out as best as you can with the information that you have. All right. So where are you submitting these AEFI forms? So you're going to be submitting them to your local public health unit. So in the case of Lillooet, that would be to Lillooet Public Health, which is there in the hospital in Sumac Suites. And then for the Lytton area, I believe it might be Ashcroft Public Health Unit. I am not 100% sure. I don't know if anybody on the call has intel on that. You could type it in the text box, but I think it's Ashcroft, depending where you're located. But it goes by the postal code and the address of the client who's experiencing the adverse event. So yeah. And you can also, if you don't know, you can email immunize@fnha.ca, and they can kind of help you figure it out of who you would be reporting that to. And if you're using Panorama, actually, you can also submit your form electronically, and it will also show you which health unit that's going to be submitted to.
Lisa just mentioned that it's generally Lillooet for the Lytton area.
Okay, so it is Lillooet. All right, perfect. Thank you
Thanks,
so much, Lisa.
All right, so I think we're going to move into our case scenarios. I don't know, were there any questions that came up so far, Carol, or? No? Okay. Does anybody have any questions? Did you want to take them up? Anybody want to go off mute for a second if there was questions on this first part before we get into the case scenarios? I know that's like quick and dirty and a lot of information, especially if you're not used to it.
So I have a question. It's come up several times from our patients. So mostly this is for people that have autoimmune disorders. One of the rheumatologists has told patients that they need to skip like 2 weeks of methotrexate if they're on that medication, or if they're on a biologic. One of the rheumatologists has said to stop for 2 months before. So is that going to be part of the screening, what medications they're on and how we handle that? Will they have to have like consent from their doctor, or is that something we can discuss? And I know it's not that they can't have it, it's just they might not have the same immune response to the vaccine.
We're really encouraging everybody to talk to their rheumatologist or talk to their physicians on their recommendations. Like for myself, I talked to my rheumatologist and she said, by all means, I have to get it. I should get it if it's being offered. And just to monitor my own symptoms. Each one I think is a little different. She didn't actually ask me to stop taking my medication. So I think it depends on what their physician recommends. And that will be some of the screening that we'll ask as well is, you know, have you talked to your doctor? So hope that is helpful.
Okay. Yeah.
Natasha, did you want to? Yeah, there we go. Thank you. So we're just going to go through a couple of different scenarios, just and for Londy's sake, no, I'm not going to act them out. Londy was asking me if I was going to act them out. Okay, scenario number one. So a client calls to report that they had a hard lump underneath the skin. It's about an inch in, and it's been persistent for the last 3 weeks after their vaccination. There are no other symptoms, and how should this be reported? Should this be reported? Before I answer, anybody have any suggestions on any comment on what the steps should be? Just from going through what Natasha shared with us. No comment.
Hi.
Hi.
I think we want to have that patient assessed by the doctor to determine if there's anything that needs attention. And then if it is something that has caused a harm to the client, then it's reportable. Like if there's an abscess or something, then we would want to report that. That's what I think.
So this is about, it looks like a lump. So it'd be a nodule that's underneath the skin, right? So with that, it would be anything over 2.5 centimeters, which just is a 1 inch. It's about the same. Anything that's there for more than, I'm just trying to pull that up, Natasha. Where is that?
Yeah, so remember, you're going to want to, whenever you get a report from a client, you're going to want to cross-reference with that criteria, reporting criteria.
And I think with this, it would be reportable because it's greater than the 2.5, or is 2.5 or greater, and it's been persistent for more than, I think 24 hours, 70 or 72 hours.
So with the nodule, it has to be a month. So if you look up, I know you don't have the criteria in front of you.
I know, it's actually.
I have it here.
Okay.
And it's, so with this one here, it's at the 3-week mark. So it would be.
Almost.
It would almost be. So you're going to, want to get them to watch it.
Yeah. But if it's greater than a month, then you definitely would want to put that on an AEFI and to submit that. Any questions on that one? Thanks, Natasha.
No worries.
Let's go for the second one.
Yep.
So a client calls it to report a fever of 39 degrees Celsius in conjunction with pain, redness, and swelling on the left deltoid, which extends from the top of the shoulder and past the elbow. And its symptoms been started 4 hours post-immunization. How should you report this? So Angie has a comment. Oh, her battery's low. Sorry, Angie. Hopefully it can hang on. So basically, this is a local reaction crossing joints and fever in other defined events of interest. So it's a reported criteria. This is a reportable criteria because it follows both pain and redness and swelling and extends past the nearest joint. So this is definitely something that you're going to be putting on your AEFI. Okay, next one. You have a client presenting to the health center with a post-immunization reaction concerns. He has a low-grade fever for 36 hours after immunization. He was sleepy, sleepier than normal. it does not meet the AEFI reported criteria, how would you discuss this with him? So basically with this, you're going to want to look at what are some of the measures that he could take at home to try to support some of these symptoms. So making sure that, you know, if he has a low-grade fever, is, you know, not overdressing, making sure that he's comfortable, but, you know, cool compress, Tylenol if you can take it, or ibuprofen, and just monitoring his symptoms too, and just trying to keep it, because it isn't reportable like on the AEFI, just monitoring that. But if it persists, then to reach out again. And I think as nurses, we need to be able to monitor him too, just to see in time.
Awesome. Thank you so much, Carol. And with any AEFI reporting, we do, as nurses, we have a really awesome resource with the Immunize at fnha.ca that you can reach out to if you have any questions, and they're usually pretty good at responding. I know with COVID, it's maybe been a little bit delayed, but normally they're pretty good at answering those kind of questions. And you can also always reach out to your practice consultants too, and we can kind of help go through those scenarios with you. All right, so we're going to move right on into management of anaphylaxis in a non-hospital setting. All right, so I'm going to just kind of run through this part pretty quick. This can be studied at length, obviously, of what anaphylaxis is. But anaphylaxis is can be very deadly, and it can result in shock. So it's a very, very important event that needs to be responded to in an urgent manner. And that is why we carry the epinephrine, the medication, to counteract this at all of our immunization clinics. So it is deadly if it's not caught or treated early. And for this reason, it's very important to be able to identify and discriminate between what anaphylaxis looks like and then what other reactions are. So we're going to look at some other reactions, mainly fainting and anxiety, because some of the symptoms are similar to anaphylaxis. And so we want to be able to differentiate that. And that's going to be really important for those of you who are watching the people in the monitoring area. So on YouTube, there is a couple of videos. I'm not going to play them here today, but I would, when we send out the slideshow to the group here, I would strongly recommend, if you're interested in learning more. I'm very visual, and I find processes like this really help me to understand stuff, and it makes more sense if I watch a video like this. So have a look at those. They're pretty interesting and engaging to watch. So anaphylaxis basically is a life-threatening IgE, and that's just an immune response thing that mediates a reaction that results in sudden systemic release of allergic mediators. So you're going to get your histamines, your leukotrienes, your prostaglandins, and your tryptase, and those are going to be released from your mast cells and your basal cells. The biggest one there that causes the most problem is your histamine. It really creates a lot of the catastrophic things that happens in the body. It causes the blood vessels to vasodilate, which means it makes them wider and bigger. And it also, between the cells in those vessels, they kind of open up and fluid starts leaking out of your veins and arteries, and it leaks into your extracellular spaces. And that is why you're going to be getting all that swelling in your body and stuff like that. And those hives, the raised, I can't figure out the word now. The raised parts in your body, they're puffy. So that is why that is happening, because there's fluid leaking out. And you can imagine if fluid is leaking out, how dangerous this could be, because within 10 minutes, this vascular permeability creates a transfer of as much as 50% of the intravascular fluid into the extracellular space. So huge concern for your blood supply is decreasing by 50% in such a rapid cascade. So then you're going to end up with what we call a hemodynamic collapse, which is your body is basically going to be collapsing. Your blood supply is collapsing. And if your blood supply is collapsing, those wonderful red blood cells that carry oxygen to all your body is collapsing. So you're going to have a lot of issues there. And then another issue that the histamine also affects is your lungs. So it attacks kind of your bronchias in your lungs, and it causes those to constrict and to have spasms there. So that's why you're hearing that hoarseness and the closing up of the breathing tubes in your body. Anaphylaxis is rare. With the COVID vaccine right now, with the information that we have, the occurrences of it is 1 to 100,000. So this is higher than the regular vaccines because the normal vaccination of all vaccines is 1 to 1 million. So right now it is a little bit higher. And what they're realizing is that some of these anaphylactic reactions are associated with unknown. So these are unknown allergies to one of the compounds of the vaccine, and it's called polyethylene glycol, short name PEG. This is a very common ingredient in laxatives and in different like cough syrups and stuff like that. But if people don't know that they have a allergic reaction to this, then they could possibly end up with an anaphylactic reaction when they're receiving this vaccine. So there's still more research and studies obviously going on with this PEG, but the PEG is really important in the vaccine because what it does, there's a fat molecule that carries the mRNA, and the PEG kind of helps stabilize it and keep it together. So it's important in there right now, and they don't have a replacement for it as of right yet. So some of the cardinal features of an anaphylactic reaction is itchy, and then those hives you're going to get, and hives are really common. So really think hives. If you see hives, think anaphylaxis. 90% of cases of anaphylaxis have hives. So very high chance if someone is going to be experiencing anaphylaxis, you're going to see that. So there could be progressive painless swelling. So there could be swelling around the face, the mouth, which might be preceded. So that would happen before the itchiness, and there might be tearing and nasal congestion and redness in the face before that swelling happens. Respiratory symptoms can also be a part of this. So sneezing, coughing, wheezing, labored breathing, and upper airway swelling. So you might hear some hoarseness in the individuals, or they might report difficulty swallowing or some tightness in their neck. So this could cause airway obstruction. And then if this goes untreated, it would cause a rapid decrease in the blood pressure, and the heart rate would become really, really fast. And we wouldn't get to this point because we would be able to recognize it hopefully before that point, which is why we have the monitors. And then, but if it did get to that point, it would result in shock and collapse for the person. Also, in anaphylaxis, sometimes we do see nausea and vomiting. Any questions about that? I know that was really fast. I talk fast. I'm a newfie, so. I hope I didn't drop any of my H's.
And I think also just to put this out there, that this is more information for our support people, just so that you know what to watch for in an event of an anaphylactic. So you know what to watch for the people who are waiting their 15 minutes.
Yeah. Thank you, Carol. All right, so anaphylaxis management, what is the responsibility as immunizers? So we want to learn to recognize early symptoms of anaphylaxis. We want to create and always carry an up-to-date anaphylaxis kit, which we're going to be going through, and I'm going to show you what one looks like. And then we want to make sure we're reviewing and practicing our competencies in case of emergency, which is what we're doing now. And also make sure our DSTs, DST stands for Decision Support Tool, they're up to date. So those are your flow charts and stuff like that, which we're going to look at. We don't need to update them. They get updated for us. All right. So I just want to go through a few differences between fainting, anxiety, and anaphylaxis. So this information is found in that section, chapter part 3 of the immunization manual. I'm just going to pull that up here for you guys because we're going to have a quick little look at it. So this is what the anaphylaxis in non-hospital settings looks like. It's part of the CDC manual. And you're just going to scroll down there inside of this, these guidelines. There is a nice little chart, and it kind of differentiates the difference between anaphylaxis, fainting, and anxiety. Do you guys see any major differences that are standing out to you? Anybody? All right, so one of the main differences you can see here, this one stands out to me big time, is the flush red blotchy areas. That's what you're going to see in anaphylaxis, but in fainting and anxiety, what are you going to see? You're going to see paleness, you're going to see perspiration, you're going to see cold and clammy, okay? So you're not going to see this swelling kind of reaction that's happening in fainting and anxiety. One of the similarities is there's rapid onset, sudden onset, sudden onset. So they all happen kind of quickly. These two, this one is, it's progressive. So if it's not treated, it gets worse. These two, they will usually recover within 1 to 2 minutes. People can usually be stabilized and be okay. Usually with anaphylaxis, you're going to see progression of symptoms, like I said, fainting. You're going to have an unconsciousness. It's going to be temporary, and it's going to be caused by diminished blood supply to the brain. Anxiety is your protective psychological state, recognizing fear, apprehension, and worry. So the differences in the respiratory symptoms with your anaphylaxis, you're going to have labored breathing, hoarse voice, throat tightness, rapid breathing, wheezing, coughing, nasal flaring. You might have a runny nose, watery eyes. There might be shortness of breath. So in fainting, breathing is going to be normal, or it might be a little bit shallowed or a little bit labored, but people won't be reporting that closing in of their throat feeling and swelling in their mouth. And then with anxiety, the breathing could be rapid and swallow, like a hyperventilation. With the cardiovascular, there's some differences here. So with anaphylaxis, you're going to have a weak and rapid pulse. Blood pressure is going to be dropping. And with the fainting, you're going to have a slow, steady pulse. And with the anxiety, you're going to have a rapid pulse. So your heart rate's going to go up. So all of these have a possibility of nausea, but anaphylaxis is the one that would have more common vomiting and diarrhea, or abdominal pain, cramping, and then the difficulty swallowing. All right, so hopefully those you can kind of see like a little bit of difference between anaphylaxis, fainting, and anxiety. A lot of times with anxiety, you will be able to notice this when the person comes in how they're receiving their vaccine. And this is a conversation you could have with them during the counseling, the consent that you're obtaining to, when you're reading their body language, to be like, have you ever fainted with a vaccine? Or do you have any fear of needles? Those kind of things. All right, I'm just going to bring up my other screen again.
And also, just to bring back to that, the nurse, if there's going to be anybody if anybody does end up going through an anaphylactic reaction, the nurses are there to support that. You, as a support person, you're just going to be monitoring them and passing on that information to the nurses that are in their immunizing.
Absolutely. Nobody, the nurses will be responsible for to doing the pulse and all that stuff. It is just really great to have lots of eyes, because we're going to have a lot of people coming through. So that's where the support people can come in and help out in that way, and maybe calling 911, which we'll get into. All right. So this is just, again, a little summary of what the signs and symptoms of anaphylaxis are. And then we have some case scenarios that Carol is going to share with us.
I guess unmute first. That's always helpful, isn't it? So we have a couple of scenarios, and first one. So Suzanne, the CHR, requests an influenza vaccine. You administer the shot into her right deltoid and then ask her to sit and wait just outside the clinic room for her 15 minutes. A few minutes later, you suddenly hear commotion outside your room. You leave quickly to find Suzanne lying on the floor. The administration staff attempt to talk to Suzanne and surround her, but she doesn't seem to be able to focus and listen to their voice. You observe that Suzanne is conscious. However, she looks pale, feels cold and clammy to touch. You observe that Suzanne is breathing rapidly and each breath is shallow. You feel for her radial pulse, which is very rapid. Suzanne is not paying attention to you. Verbalize what you think is happening to Suzanne. What do you think is happening to her right now? Thinking back about what Natasha talked about with the difference between the anaphylaxis, fainting, and anxiety. Sonia, yes, Sonia said fainting. She fainted. That's totally it. She did. She just had one of those reactions where she ended up fainting, and that happens. And just like Natasha was saying, one of the most important things as immunizers, we always, like for myself, I always ask, have you had any history of fainting? Is this something that that happens to you? Same with anxiety. We ask those questions all the time.
And we had a answer here of anxiety too. Yeah, it might be anxiety as well. It's but it's definitely fainting because she lost consciousness.
Thank you. So next question. Scenario number 2. So Jamie is in the clinic for a COVID-19 vaccine. You administer the first dose. Jamie flinches when you give her shot, and she seems to be in a lot of pain. You then ask Jamie to wait outside your clinic room for 15 minutes. Just as she is about to say she's feeling like throwing up and feeling dizzy, Jamie becomes pale and slumps into the ground. Her skin feels cold and clammy to touch, and her radial pulse is steady and her breathing seems normal. What do you think is happening to Jamie? Anybody want to unmute and just verbalize that or put it in the chat?
Is that maybe anxiety?
Anxiety and a little bit of faint too, I would think. So with that, what you want to do is just making sure she's comfortable, right? You want to make sure that she isn't going to fall, that she isn't going to hit her head. She's, that Jamie is safe. And you want to make sure that if she is feeling like she is going to throw up, making sure she is not laying down and can't breathe properly. So just making sure she's in a good position.
Absolutely. And then also remember the blood supply to the brain, right, is what the issue is when people have these fainting episodes. So what could we do to increase the blood supply to the brain?
Breathe into a paper bag, maybe?
Yeah, for anxiety, that could help really well. Yep.
Get her to lie down.
Yeah, that's right, Carmen. So getting someone to lie down and put their feet up would help kind of get some of that blood back into the brain. Awesome.
I think this is there's a third one, right? Okay. So we have Daryl, and he's a 19-year-old. He came to the clinic for COVID vaccine. You administer the vaccine, and within 3 to 4 minutes, Daryl complains of a headache and tells you his skin feels itchy. His skin quickly breaks out into a blotchy rash. Daryl tells you that it's difficult for him to breathe and he can't catch his breath. He becomes very visibly distressed. What do you think is happening to Daryl right now?
That the allergic reaction?
Completely. And you see that the time frame, it's been like 3 to 4 minutes since the onset. He has getting a headache, he's getting itchy, he's developing a rash, he's having difficulty breathing, all different signs of anaphylaxis. So immediately, this is where as the support people that you there, you're going to notify the nurse right away. You're going to let her know right away so that they can start the process, the anaphylaxis process. And also too, I think it's important that during this, there's always going to be one person designated to be calling 911, because you want to make sure that whoever has that position to call 911 reports back to the nurses as well. Scenario number 4. So we have Tamara, and she's a 29-year-old who is 4 weeks postpartum. Her doctor has recommended she take the COVID vaccine. You administer into her right arm. Tamara waits for 15 minutes in the clinic. When she is ready to leave, Tamara tells administration staff that she's feeling unwell. She describes a tight feeling in her chest and feeling that she can't get her breath. You call out for the clinic room. You find Tamara looking unwell. She looks flushed, and she tells you that her chest feels tight. Her breathing seems wheezy, and you observe the puffiness on her face that was not there earlier. You ask Tamara if her face and mouth feels tingly, and she nods yes, and it becomes difficult for Tamara to speak. You check her radial pulse, and it's very rapid and weak. So what do you think is happening? Anybody?
That kind of sounds like an allergic reaction to me, but
yep, it is. Because you think about it.
I'm not too sure.
Yeah, because it doesn't have to be within the first few minutes, right? This is just that the first few minutes is most common that you would see this anaphylactic reaction, but it can take a 15 to 30 minutes depending on what's happening too. So for Tamara, you're definitely going to initiate the anaphylactic protocol. Okay. Any other?
And I think the temporal criteria for anaphylaxis is 0 to 24 hours. So sometimes it can be delayed as well.
Yeah, totally.
Not frequent, but it can be.
Mm-hmm. And another reason why we really encourage our clients to stay for the 15 minutes, just to making sure that, you know, that first 15 minutes are the crucial ones for sure.
Absolutely.
So I just have a quick question. So if someone presents that has had anaphylaxis in the past and they're on a beta blocker, would we still give them the vaccine at the clinic, or would we recommend they get it at the hospital just because the beta blockers prevents the epinephrine from working properly?
That's a great question. And I would probably defer to your second part of that, where they get it in a more controlled setting.
And is that an option for, like, would that be an option for people?
I think that's an arrangement that'll have to be made with our local health authority too, right?
Okay.
Yeah.
Yeah, so they would kind of fall under the criteria of checking with their doctor, and that wouldn't be something we would take right there in the clinic on that day.
No.
All right, thank you so much, Carol. So important to know that anaphylaxis about the anaphylaxis treatment and documentation. So epinephrine is our first line of defense when we're responding to an anaphylactic reaction. And epinephrine is a very safe medication, and we should not delay its use. Sometimes individuals might, if they're having an anaphylactic reaction, they might not even have any respiratory symptoms. They might just only have hives. It's okay to give epinephrine in those cases. The amount that we give in community settings is so low that it's better safe than sorry if they fit into any of the criteria for anaphylaxis protocol. So we inject this medication into the vastus lateralis, which is the large muscle in the thigh. And the reason we do this is because it absorbs much faster in this muscle. And we've also noted that plasma concentration of epinephrine may be up to 5 times higher when administering intramuscularly into the vastus lateralis as compared with subcutaneously or deltoid. And also this is a great location because with the COVID vaccine, the recommended route for administration is the deltoid muscle. So this will be a free limb to inject into. So the action of epinephrine, so what happens when epinephrine enters the body is it counteracts that histamine-induced vasodilation. So it creates the opposite effect. It increases the heart rate and how the heart pumps, so it makes it stronger. And it also then increases the oxygen supply in the blood and then onward to the vital organs. It also acts as a smooth muscle relaxer for the bronchial trees, so it relaxes all the airways so that people can breathe, and it slows down that histamine cascade. So there are obviously, again, side effects of large doses of epinephrine, but in community, we're not going to be giving those large doses. So that's not of a concern to us. And if we did know somebody was more complex, we wouldn't be immunizing them in community. So everything we need to know about anaphylaxis, this is what we call our DST, or our decision support tool that we use within this emergency situation. And this can be, again, found on the BC CDC website. I'm just going to pull it up here so you guys can see the whole document again. So that was contained in there, but it starts like this. And then when you go down, you're going to be able to find that DST. It's right here. So emergency treatment of anaphylaxis. Okay. All right. So you're going to, again, be injecting into the vastus lateralis. These are the doses. This little schedule part here is very important to have. And for the COVID vaccine, we're going to only be following the bottom line here, which is the 0.15 mils, because we're only going to be doing 19 and above in these clinics. So we can disregard the top portion here. Epinephrine, it needs to be given 1 inch away from the injection site, but because we're doing it in the vastus lateralis, we don't need to worry about that. And it can be given through clothes if necessary, especially if somebody's having a very rapid, severe reaction, then by all means, give it through the clothes. So these are very important parts to make sure we're documenting on our worksheet, which we're going to have a little look at the worksheet here now too. So what we want to make sure we're documenting is the dose, the time we're giving it, the route we gave it in, and then we're also going to want to document when we called 911. All right, so the documentation is found on that surveillance link that I shared with you guys. I'm going to pull up the documentation and we're just going to have a quick look over it just so we can familiarize with it, because there's nothing worse than going into an emergency situation and not having seen the documentation before. So you're just going to start the form by putting the person who completed the form, the date of the report, date of the event. This is the little box that contains all the client information, their name and PHN. Try to fill out all the lines as much as possible. I know sometimes in community we don't use PHN a lot, but with this vaccine, we're going to be relying on this, so we will have this hopefully. And then there's a little chart here for documenting the epinephrine. So you want to be taking the pulse, the respirations, putting the time down accurately, the lot number, the route, the dose, the site, and who administered it, and their signature. And then it has 3 doses because that's as many doses as we can give in a community setting. And then you want to make sure you fill out all these boxes here, as well as there been a history of prior anaphylaxis, history of other allergic reactions, and then you want to write in all the transfer information once you get that, and the vaccine that you provided. This page here kind of goes into what the symptoms were, and what is being asked is that you fill out every single one of these. And it's, if you didn't assess it and you realize that after, that's okay. Just make sure you check it off that you didn't assess it, and just check off yes or no for only the things that you know for sure they didn't have. And if you don't know, then it's okay to just put unknown or did not assess. So there's quite a few different symptoms there. And then at the end, you're just going to make sure you put your name down here and your health authority branch number. And then there's a nice little appendix that goes through all the terms and like a how-to kind of sheet. Any questions about that form? Hopefully it's pretty straightforward. All right. So if there's no questions right now, I know
I don't see any in the chat.
Okay, perfect.
I'm curious if anybody had a situation like this. I have, so I'm just curious if anyone else has.
So for myself, you know, before I became a practice consultant, I was a community health nurse for 19 years, and I never experienced, yeah, never had that. Yeah, never had anybody go through an anaphylactic reaction.
Anybody on the line who's experienced it?
Mm-hmm.
Who's experienced anaphylaxis?
Who's like responded to one in community, like after giving a vaccine
or even receiving a vaccine.
Okay, yeah, I have experienced it once actually. So I think out of all of us nurses, that's pretty crazy. Some of us have been in there for a long time, but I experienced a very mild reaction one time. It turned out to be hives, and I guess the specialist then after said it wasn't an anaphylactic reaction, but the person broke out in hives right after the vaccine. So I gave epinephrine, yeah, and it stabilized the client.
It's better to be safe than sorry. So that's I think that's a takeaway sometimes.
Yeah, and that was kind of the feedback that was given to me. And I always like to say that because of that, that there's no harm in giving it in that situation, because as we know, 90% of the anaphylactic reactions have hives. So very important. So Pat is saying she experienced my grandson once at an airport prior to him having an EpiPen. Yeah, it's really scary.
Mm-hmm. Especially when it's your own family member, for sure.
Mm-hmm. And Sue says her mom got severe hives from penicillin.
Mm-hmm.
Wow.
I had an anaphylaxis reaction to penicillin. Oh, this is Tabitha Leach, by the way.
Oh, hey Tabitha, how's it going?
Hi, Natasha. Oh, you know.
Wow.
Living the dream.
So you survived your anaphylactic reaction though. So did you have an EpiPen at that time?
Yeah, I did. And the first thing that happened within minutes, my lips got big. Like my lips got super big, and then it just became really hard to swallow. And it happened within minutes. Wasn't very long. So yeah.
Wow, thank you for sharing, Tabitha. Yeah, that's usually, in most cases, not all cases, obviously, it usually happens within minutes, and the 15 minutes is suffice in most circumstances to monitor for that anaphylactic reaction. So, yeah.
Hello, it's Londi. I just want to say that although I'm an FNHA employee, my background is criminal justice. So, I'm glad that I clarified that with Carol, and she mentioned it as well, that you know, I'm there to support in any capacity that I can. Some of this stuff is a little over my head. So should anything, you know, severe happen, I'll just start hollering in a calm demeanor, of course, but you know, it's a lot of information and I appreciate all of it. But I'm hoping that I can just manage some of the people on the way in or something, because this is really not, and I don't want to be negative, but I just want to be put where I'm going to be most useful. Thank you.
Absolutely, Londi. We're not going to expect you to respond medically. There is going to be, in most of these clinic situations, 4 to 6 nurses. So a lot of times we might not even have to use some of the support staff, but this is, yeah. So don't worry, we won't have you in there doing any of that stuff.
Thank you.
I know it's daunting. All right, is there any more comments or questions before we move on?
I just think a quick question or a comment. So Londi, yeah, so I think it's good for even non-nurses to know this, because if you see something might just, you know, somebody, you know, just left after their 15 minutes and you see them, you know, see some kind of symptom as they're going out, you could report that to us. We don't expect you to, you know, give anything, but just to, you know, you'll notice things are different, or if somebody's from when they came in till they left, you know, or we might say, you know, call the ambulance for us, those kind of things.
Yes, thank you. Yes, that I can certainly do. Yes, thank you.
Awesome. Thank you so much, Pam. All right, so this is what we keep in our epi kits or epinephrine kits. So the first thing you want to have in there on hand is your BC Cdc guidelines. So that is the document that I pulled up. I keep a little booklet like this here in my kit. You also want to make sure that it is updated, because these get updated regularly. The last updated copy of this I checked online was June 2019. So please check your kits and make sure you have the most recent copy of this. And then the second thing that I like to do with this is I like to put a little sticky tab on the page where the DST is, so that I can open it and access it very quickly. And then another thing you can also do, especially in these cases, is you can even highlight that 14-year-old and older, so you know you're giving 0.5 mils. The second thing you're going to want in your kit is a worksheet. So that is the sheet that we went through for the anaphylaxis. And then you're going to need 4 vials of epinephrine, making sure that they're not expired. And that they are kept inside the kit and out of direct light, because it is light sensitive. You're going to also want to have in there 4 1 ml syringes and then some needles to correspond to those syringes. So we suggest, or it's mandatory, not suggestion, to have 4 1-inch needles and 4 1.5-inch needles. So this 1.5 is just for somebody who might have a bigger arm here. That you might need a longer needle to get into the muscle. And then you're also going to want some alcohol swabs and then some pen and paper that you might need to take some jot notes on. So this is an image, an example of an anaphylaxis kit. So as you can see, this particular health center has theirs done up with rubber bands and them clearly labeled. This is a really nice way of doing your anaphylaxis kit, very organized. You can kind of see where everything is, your epinephrine, your cotton swabs, your alcohol swabs. And then also, as you can see, they have cut out of the guidelines this chart, which is a really good idea. But just when you're updating, make sure you check this every time you're updating to make sure these have not changed. And then another system, I know at the Lillooet Health Center, we have kind of like a fishing tackle sort of box. It's just one level, and it also is very clearly labeled and very easily accessible with the different supplies in there. And then at the clinics, I would definitely suggest having at least bare minimum 2 epi kits. It would be ideal if every nurse had one at their station, but I know that might not be feasible. So at least 2 kits, because in the case that two people were to have, very rare instance that 2 people were to have an anaphylactic reaction at the same time, we'd want to be able to have 2 kits to respond to those separately. So this here's just a little slide about ordering epinephrine. I'm sure most of you are already set up for ordering, but some health centers order via their pharmacy, and they have a standing prescription from the local MD. But most health centers get through the PDC, the Provincial Distribution Center, and there's no prescription needed for CHNs who have their immunization certification in order to order the epinephrine for immunization purposes. If you do require assistance obtaining epinephrine, please contact immunize@fnha.ca and they will gladly help you with that. So there is an anaphylaxis online course that if anybody on here is interested in doing that, it goes through a lot of the information I went through and maybe a little bit more different things, but it's at the PHSA Learning Hub. It's free. You can register and have a look at that and refresh your knowledge a little bit more. And then here's just a little checklist that I would suggest everybody doing. So check and update your clinic's anaphylaxis kit. So just making sure that everything is not outdated and your forms are all the latest documents. And find out how to order epinephrine or how you do order it, just in case you might be new into community, and you might want to find that out before you run into a situation where you've run out of epinephrine. And then, of course, you can do the course. Yeah, so that is the presentation for today. Are there any questions? So if you did come across questions or concerns, you can always reach out to immunize@fnha.ca and put a high priority if it's related to your clinic and it's going to impede the starting of the clinic or whatever, and they will try to answer that as soon as possible, because I know COVID is their top priority right now. And then also you are also welcome to reach out to us, your community health practice consultants. I am the community health practice consultant for the Northern Statlium communities, and Carol is the practice consultant for the Lytton area communities. All right. Any comments, questions?